Good afternoon to one and all present here. So here we are to discuss what's end of life care, and we have four esteemed panelists who will be presenting their knowledge and their field of expertise and throw light on a topic that has probably been discussed or probably been touched upon in the morning, and we are going to get more clarity on this topic. Over the last decade, India has seen almost a threefold increase in the life expectancy. That means to say that more and more elderly patients are going to live much beyond their 70s and 80s, and many people, especially those with terminal illnesses and cancers, are going to live longer lives. So the principles of end of life care are basically this, what is similar to that of palliative care, that of autonomy, beneficence, non-maleficence, and distributive justice. Intensive care in India has advanced significantly and offering life-prolonging technologies. But in terminally ill patients, aggressive interventions may only delay inevitable death, causing unnecessary suffering and financial strain. So this is what was proposed by IAPC, the 6-step process involved in the end of life care to identify, assess, plan, provide, reassess, and reflect. So a lot of definitions have been given by the European Society of Intervention and Critical Care. So that of withholding treatment, withdrawing treatment, active shortening of the dying process, palliative care, end of life care, and advanced directives. So we'll be dealing with all of these in the coming slides. Legally, when we look, we have had the case that is most commonly cited, that's the Aruna Shanbhog case, which permitted passive euthanasia and advanced directives, but the procedures are complex and impractical. ICMR as well as ISCCM, they also provide clear definitions and ethical guidelines. So between the 2018 and the 2023 guidelines, there are a lot of changes that have happened, and as was discussed in the last session, the PMB and the SMB, the primary medical board and the secondary medical board, have to be constituted, and thus there is a framework that is existing for enforcing end of life care. So what are the barriers? So prognostic uncertainty, family reluctance, physician hesitancy, and lack of communication training. So once we address these barriers, I think end of life care would definitely be much more successful. So this was given by Dr. Varki et al. So they told us what are the what are the parameters of end of life care in India, that of accessibility, the psychosocial domains, the barriers and facilitators of end of life care, the quality of EOLC and dying, the need for education and training. A lot of gaps were identified, and what were the areas of future research. So why is EOLC or end of life care necessary? It is estimated that nearly less than 3% of Indian cancer patients have access to adequate pain relief. They do have access to pain relief, but adequate pain relief is what still remains unanswered. Lack of established palliative care facilities, poor quality of death index, lack of medical infrastructure, lack of uniform guidelines or legislation. So we have progressed a lot in terms of end of life care, starting from each block being addressed separately to what is now practiced as an integrated issue based model, wherein you have the cancer assessment and treatment, and there you have separate domains for each of the issues, and they are addressed separate by the respective consultants, and there is a lot of scope for the palliative care consultant. So for the first question, may I request Dr. Raghu Thota sir, what exactly constitutes end of life care, and when do you initiate it in your institution?
Good afternoon everyone. I think it's a post-lunch session and a very important topic, something called as end of life care. Maybe naive to many of the participants, not naive to the participants, and the faculties who are sitting in the front row. So coming to the exact definition of end of life care. So now there are two ways to look into it. Okay. So broadly, if you ask about the definition of end of life care, it constitutes when we are not providing any disease directed treatment. Okay. And it may be months, okay, or weeks or days, where the patient is suffering from a life-limiting illness or a serious life-threatening illness, and where we are providing a comprehensive care like the palliative care. Like in the previous slide you said, end of life care constitutes a palliative care itself. So we will be looking all the four aspects of the palliative care. That is, we will be looking about the physical symptoms, we will be looking about the psychological, social, and the spiritual needs of the patient. So all these things at the same time, the caregivers. So this constitutes what is called as an end of life care. Now, if you look into the other aspects of the end of life care, where we are implementing end of life care in a patient in ICU, especially, so the period or the duration where the patient is going to live is very shortened. So it is just weeks or days. So it also constitutes end of life care. So it's a very broad spectrum. In this definition, you have quoted it is saying when there are life-sustaining treatments as per the EAPC, the definition which we have said. But if you take the WHO definition and the other definition, it broadly covers when there is no cancer-directed treatment. So that is what exactly is an end of life care. So what's the second part of my question?
When do you
initiate it in your institution? No, right. So if you take into account the ICU patients, okay, so if they are on life-sustaining treatments, provided the primary treating physician says that they are not going to give any further disease-directed treatment, so they are categorizing that the patient is not worthy for any further treatment, but is on life-sustaining treatments, because of which again is productivity is negative. So during that time, we initiate something called an end of life care. This is in ICU patients. Okay, coming back to the patients who are in wards or in the patients who are at home, right? When there is no disease-directed treatment, itself constitutes an end of life care. But again, coming to the time gap, some societies or organizations recommend is up to 6 months, and some organizations say it 1 year. But we at our institutes, we take it as 6 months. So the prognostication becomes a very important determinant in deciding the end of life care in this group of patients.
Thank you.
So I think the answer is clear, and if you want, I will try to further dissect it and
sure, sir. So a few of the triggers for initiation of EOLC could be something like a catastrophic brain injury, critical illness, post-cardiac arrest patients, cases of advanced or metastatic malignancy, advanced age with declining functional status, acute decompensation of chronic end-stage organ failures, worsening multi-organ failure, or any patient who express a desire against aggressive care. Any other clinical scenario where you would be surprised if the patient is alive at the end of 6 months. So this is the framework of EOLC that was suggested.
No, if you go back to this slide, please go back. So if you see, this is the third step. Okay, as for this end of life care pathway which has recently come, is a 2024 again ISCCM and IAPC consensus position statement about the end of life care initiation in India. Okay, I am a part of this task force. So the third step is where we initiate the palliative care, and if you look at early and as needed multidisciplinary patient or family meetings, including shift to palliative care only. So that is also one of the point where we can initiate palliative care. Answering my first question.
So lot of societies have given their own framework, like we have the Macmillan preferred priorities of care, compassion in dying advanced statement, and the gold standard framework. So it is an advanced statement that the patient or his or her attenders wish to give. The next question to Dr. Ramkiran sir, at what point of time do you start counseling patients about end of life care, and how would you counsel them? As we see here, from health to death, there is a lot of scenarios or lot of situations or during the time frame wherein which we can institute EOLC. So sir, where do you think would be the appropriate time, and when would you counsel them, sir?
Good afternoon. Actually, the entire shift of focus actually starts from what is called as cure versus to care. So what we have actually started is that we are going to care for these patients, and we are actually not looking at much of the curative benefits when the patient has already started with the EOLC in the ICU. So most often the counseling of the patients begin as early as possible, and once the futility of the treatment has already been established by the primary medical board, which has been constituted by the hospital, things start immediately. So it will be like an early EOLC if we have already started the discussion within 48 hours, and it will be called as a late or a delayed EOLC, which constitutes that it is considered as about 48 beyond 48 hours after identification of the futility of treatment as per the EOLC checklist. So here we need to have a team, that is a physician, the team of with a patient family as well as the palliative care team, in which the subjective and objective assessments by the physicians are being carried out, and honest, accurate as well as early communication of prognosis has been explained, and early offer of palliative treatment when poor outcomes are predicted. This has to be very mandatorily be done by the physician. And the team also looks into the consensus through open, early, as well as repeated discussion. So it's not a one-ended or one-time discussion with one family member. It will be repeated discussions with many family members. And it also ensures the consistency within the caregiver team, because we have what is called as a caregiver and what we actually call as providers. So we as providers, we always take into consideration the caregivers as such, and we also constitute a team of the important caregivers who are actually associated with a given patient, and then we need to sit and we need to chalk out, and we need to have repeated discussions about this. And transparency and accountability, it has to be done, and accurate documentation is very important during this process. And with respect to the patient and family, the communication of the decision and the conflict resolution has to happen within themselves. So it should not be like the son is going to tell that, yeah, I am happy with EOLC, and the daughter says that I am not for it. And withholding or withdrawing life support after family discussion is also extremely important. Both are ethical as such, but we need to make sure that it has been documented. And discussion of the end of life symptoms and process of end of life care needs to be done, and it needs to be well documented once again. Next. So there is a lot of difference when the patient is being seen by a primary care provider and then the patient's being seen by the palliative care specialist. As we can see on the left hand side, that the decreasing number of people concerned are now being involved in palliative care discussions. So we are not, that means only the needed people, that is the needed caregivers, are the ones who are identified and who are brought into the process of actually palliative care physicians being taken into the group discussions. And the other thing is, on the right hand side, there is an increased level of complexity as well as an expertise which is required from the palliative care team, and they are the ones who are going to provide further discussions upon this. So there are a few terms and definitions which we need to understand. One is which is called as a DNAR, that is do not attempt any resuscitation, in which the decision not to initiate or perform the CPR, that's the cardiopulmonary resuscitation, has been taken. We have already come across this term palliative, that is passive euthanasia in the morning. And passive euthanasia is when actually it's either been done with two things, that is either a WHLS, that is a withholding the life sustaining support, or by WDLS, that is withdrawal of the life sustaining treatment. So these two constitute the passive euthanasia, whereas active euthanasia is not been practiced. It is not considered ethical in India, and that is mainly in form of the physician assisted suicide. And palliative sedation being it as a one more pro-con, I am not going to deal with it much. So the recommendations from the EOLC, it must be embraced that it is a compassionate and ethical approach. It is not a financial fallback when when all the ICU resources have been outsourced. And there is one very important thing what we need to ensure in end of life care, that is what is called as a LAMA, or the terminal discharge, what we call in the ICU. So living against the medical advice and terminal discharge from the ICU should not be happening in end of life care. So these two are ethical standards of beneficence and non-maleficence, and it just means that we are abandoning the patients without giving any proper palliative support. In such cases, we need to handhold these patients, and we need to make sure that they don't actually go on with respect to a LAMA or with respect to a terminal discharge. Only because the management or the hospital administration wants it, it should not be policy as such which needs to be put forth. And there is a lot of legal clarity which is needed for both the withholding the life support as well as the withdrawal of the life support. But until then, the clinicians must act with moral integrity. And offering any futile treatments, prolonging the suffering, prolonging the ICU stay, denying the patients the dignity of a peaceful and a natural death should not be done. And the path forward will be recognizing the EOLC as genuine care, but not as a last resort. So these are the last few guidelines from AIMS, which has actually told with respect to the recognition of the futility, first of all. Secondly, the clinician consensus on the futility of further management. early and detailed explanation about the prognosis with proper communication, documentation, assessments before the initiation of EOLC, continuous assessment on a daily supportive plan. So it should not be that I have done it today and I have left it. It should be a continuous process. Daily supportive care plans are being devised and documentation of daily progress notes are being done with. And finally, our feedback is also sought from the caregivers.
Raghu sir and Ramkiran sir, where would you prefer treating patients in end-of-life care? Is there a role for ICU care in end-of-life care?
So that is what I told you. So there are two aspects to look at for the end of life care. So suppose the patient is admitted in ICU and the futility is been diagnosed there, we can provide. So it is not that you have to provide always end of life care in ICU. You can provide in ICU as well as you can provide the patients even in the ward, as well as the patients who are admitted in your palliative care unit, or as well as the patients who are getting the home care. So there is no barrier to this. Okay, it is very clear cut. So once the futility is established, and the futility first has to be established by the primary treating physician. Once the futility is established by the primary care physician, then comes the primary medical board who establishes and authorizes that futility. Okay, yes, this is done. Okay, so then the palliative team is initiated. Okay, or we will get a call or we will get a referral saying that, okay, now this is the futility and now we are going ahead with the withholding or withdrawal of the life-sustaining treatments. If is the patient, most of the patients, if you are talking, and whatever we are talking about this end-of-life care, about withholding and withdrawing life-sustaining treatments is meant only for ICU patients. To be, this is for the participants. So don't get confused. So end-of-life care is in two ways. Okay, but whatever the pathways which are been shown that are precisely and particularly only for the ICU group of patients. Okay, so once that is initiated, then the palliative care team gets activated, and then the primary medical board, palliative care team, and then you get in chip in the secondary medical board, which authorizes the primary medical board, and then the hospital sends a letter to the what we call it is the district magistrate or the collector of that particular area. Now there is a, just to clear the confusion, now the Supreme Court has not made it very clear regarding the secondary medical board, in the secondary medical board, that there has to be one physician who is an unbiased physician who will be selected by the CMO. Okay, Chief Medical Officer. Now district has a Chief Medical Officer, but what about the cities who are, whether they have a Chief Medical Officer? I think Bangalore city falls into the category of municipality, right? So they don't have a Chief Medical Officer. Municipalities doesn't have a Chief, Bombay doesn't have a Chief Medical Officer. So I think it applies to Bangalore also. So for that sake, Karnataka High Court has done a very good change by giving one statement saying that in that case, if you don't have a chief medical officer who can nominate one physician, then the Organ Transplantation Act board which is there. Okay, so one of the physician can be from that board. So I don't know whether that can be extrapolated to other states. We are working on it through IAPC and through ISCCM. We are really working hard to get into that and get the Supreme Court to make it amendable in the next judgment which they can pass it. So falling back to the question, okay. So yes, there is a role for ICU for providing this end of life care, but again we have to see to it about the resources which we may be utilizing, because ICU is mainly for the dynamic treatment or for the treatment where there is certain curative intents. But it is not that there is no role of an ICU. We can initiate end of life care in ICU.
Sure, sir. Ramkiran, sir.
So the most important focus of EOLC now actually focuses on the comfort, dignity and symptom control. As I already told that rather than the cure, we are looking at these parts. And it also includes three important things. That is, one is a DNAR record, WHS and WDLS. And all of these are considered ethical. Although we need to differentiate between two things here. One is with respect to the withholding a life support and withdrawal of life support. Withholding means like I need to withhold the onset of a dialysis in a given patient who is already having a renal dysfunction. So in him, I'm not going to start or initiate the hemodialysis. So this is something which I need to put forth. So I have a discussion with the primary team. I have the discussion amongst the caregivers, and then we need to formulate that I am not going to do this. But at the same time, the WDLS is what is called as a withdrawal of life support. That means I have already initiated a treatment. I have put a patient on ventilator, and at the end of it, I know that it's a futility. It's a hypoxic injury which has already happened, and the encephalopathy has already set in. And now, if I take the decision of withdrawing this patient from the ventilator, this becomes a WDLS. So a lot of ethical issues becomes of primary concern here, because by judiciary, DNAR, WHLS and WDLS are all approved. But when it comes to our physician ethics, probably WDLS will not be part of our discussions. So I would like to insight more from Dr. Raghu also on this topic of WDLS.
So I have a different aspect to it. So it doesn't matter. That is what I'm saying. For example, withholding and withdrawing, right? Withholding what? For example, if you take a patient who is on a ventilator. Okay. So now you are withholding it. Okay. So you are not giving anything. Withdrawing. Again, you are not giving anything. So ultimately, it is the same. It's just a grammatical differentiation about withholding and withdrawing. Ultimately, you are doing it ultimately it is the same thing. So ethically, if you ask me, the outcome is the same. Whatever you're doing is the same. But only if you take it as an English language, both terms are different. That's it. So it's not a major difference about that. That is what I'm saying. So that is what it is. So physicians, whether they are like you said, whether they have a profound effect or whether they accept ethically the withdrawal you're talking about. So I think there is nothing wrong in that. Only thing is that they are not used to doing all these things. Now it is a legal thing, and it is legally right, so we can do those things.
So a lot of things also happen with respect to dynamics in ICU in end of life care. We need to have decision making about the life support. We need to make these goal alignments of giving a good quality of life as well as quality of dying. So quality of dying has actually taken more preponderance now in EOLCs. And we don't see just the quality of life henceforth, only because the patient is suffering with respect to a lot of interventions, does no justice further. And family and patient input also regarding the ACPs are extremely important. We need to make sure that the sentiments of the family are also kept intact. And the comfort and symptom management of a given patient also needs to be considered. And terminal weaning with medication to ensure patient comfort may be considered in extreme situations in which we are very sure that the patient will not sustain beyond 48 hours. And integration with critical care, the shift in focus from life sustaining to symptom management. Symptom management has taken more importance now in most of these ICUs. Actually, there are dedicated palliative care ICUs in which more of the patients, bystanders can be let in. There will be no fixed timings for visiting, and they can actually take decisions along with the patient if the patient is in a position to take the decisions. And integration of critical care and palliative care teams will always be there in such settings. And the quality of dying and ensuring dignity is the one which is going to be maintained in such scenarios. So most important symptom controls, what we usually encounter in most of the ICU settings will be like prior to withdrawing during the weaning, what exactly we can do, giving injection midazolam, giving injection morphine as required for these patients who actually, we know that the futility is definitely there. And patients who are having dry mouth, who have pain, who have nausea, who have dyspnea, these are the ones who need to be taken with respect to the symptoms. So we shouldn't be worried much about providing curative aspects at this point of time. And we need to make sure that the patient has comfort and they have a peaceful stay in the ICU. Anything, sir, to add?
No, that is definitely going to happen. Okay, so now once a decision has been taken that, okay, everything has been sorted out, and now we are deciding that the patient has to undergo withdrawal or withholding, whatever it is. Okay, so there are main two drugs. Before that, as you said, suppose if she's on ventilator and all, we have to dry out his secretion so that there won't be any something called as a death rattle. We call it as that noise, that secretory noise should not come when they are breathing in and all. So all these medications are ongoing, but the most important thing is something called we call it as palliative sedation now, right? So here we are initiating palliative sedation so that there is an amnesia and the patient has no distress, okay, when we are losing him. So that is very, very important. So we can start either by using a midazolam, but midazolam is a very short acting medication, or else we can give other medications like propofol can also be initiated. It is not that we can't initiate. So these are the medications which take a major role when you are initiating end of life care rather than the other medications, though other medications have a important role.
So in end of life care, especially in patients who have opted for DNAR, what are the circumstances where you would like to shift the patient to the ICU, and what would be your treatment goals, Dr. Mallika?
So basically in end of life care, getting into the heart of ethics, we should basically understand what the DNAR status means. It never means do not treat. We have to treat, especially they need active treatment. Even if there is any medical, any crisis like sepsis, pneumonia, which is in place, they do need active treatment. So when can a patient with DNR be shifted to ICU? When do we have those reversible conditions in which we can get them back out of it, but not resuscitate if there is death. So probably that is where we can, that can be our goal to shift. For example, sepsis, pneumonia, like I said, and the rationale should be the patient wants maximum therapy but away from CPR. So what can be some of the situations? Irreversible multi-organ failure, any patient goals emphasizing on their comfort, that's a TLC, tender love and care. Transfer would impose unnecessary suffering without any realistic benefit. You need to consider this where, what can our goal be? It should be dependent and agreed upon to the scope and care of the patient or the patient caregiver. Broadly, they receive certain symptomatic relief and comfort like pain, dyspnea, agitation, delirium, like Sir said, palliative sedation, oxygen or any non-invasive ventilation, fluids, antibiotics as and when necessary. Any avoidance of any burdensome interventions like dialysis, mechanical ventilation when they do not have any outcome, and especially if it's agreed upon. Also, coming to treating the reversible causes, like infections, electrolyte imbalances, has to be treated, especially if it's consistent with the patient or the caregiver's wishes. Time-limited trials is what we need to consider when you're giving treatment for these patients in ICU. That is, keep a goal of around maybe 48 hours. See if you see any improvement of condition. That is what you can discuss upon with the caregiver before shifting. That is, keep an end point to the treatment. If there is no improvement, probably get back into the comfort focused care. Most important thing will be the communication for any advanced care or planning. Maintain the ongoing dialogue with the patient or faculty as family as necessary. Again, any intervention we are doing, it is important that we clarify as to why we are giving and what we are doing. For example, I'm giving fluids and antibiotic, but I'm not doing CPR. So they need to understand what the rationale behind this is. Key principles that, like I said, most importantly, DNAR does not mean do not treat. Individualize each patient to their particular prognosis and preferences. Keep a goal-directed treatment and be clear upon what you say to the family. Have an interdisciplinary approach. Talk to the primary physician, which is the most important thing. So in summary, I would say that shift the patient into the ICU if by doing so you're aligning with the care for any reversible condition or comfort giving, but not for resuscitation.
So you mentioned about advanced care plans. So Dr. Divya, what do you think are advanced care plans, and who do you think should lead the discussion educating patients and caregivers?
So advanced care plans are it's basically an ongoing process where the primary care physician discusses with the patient and their immediate family and caregivers regarding the disease and its outcomes, and what are the possible treatment options that are available. And they also should they'll also discuss the goals and beliefs of the patients, and it can document like advanced directives to ensure the patient's goals are followed later in a situation where he may not be able to take any decision by himself. So the steps in this, basically we first introduce the topic. It's best done by the primary care physician. It's always best in an OPD setting when the patient gets to know, or when you know that the disease is in an irreversible state, or the patient will not benefit much from life-sustaining treatment whenever he needs it. So at this situation, the patient and their family will be in a better position to understand what they are going through, and they'll have time to process it. They won't be stressed to take a decision in due to shortage of time. After this is structured discussion, and whatever the patient's beliefs and their expectations from life and treatment will be understood better, and these preferences should be documented well. And it has to be kept in mind that the advanced care plan should be reviewed and updated periodically, especially when the patient's healthcare situation changes, and as and when needed, the advanced directives should be applied. So advanced directives are basically legal documents which lay down the patient's beliefs and expectations, and helps decisions to be made by when the patient is not able to make on the patient's behalf, when the patient is not able to make a decision by himself. For example, we have living wills where if the patient wishes to deny CPR being done, or the patient does not want to be put on ventilator, or does not want to probably does not want to get admitted to an ICU, these things will be documented. Another thing is the patient may appoint surrogates. This would be a power of attorney to take healthcare decisions on his behalf when he's not in a state to take such decisions. So the benefits of this would be benefits of applying advanced care plans would be reduced hospitalization at the end of life, increased usage of hospice care. The patient would get to pass away peacefully at a place of his a place of his preference. It'd be and of course there'll be lesser ICU admissions towards the end of life. There'd be better satisfaction among the patient and their family with respect to healthcare. There'll be more patient comfort and satisfaction. Also, they reduce a lot of cost and stress to the family members as well. And overall, the unnecessary ICU admissions can also be minimized. So, to apply document advanced directives in India, it has to be done in the presence of two witnesses who are completely unrelated to the patient and not from the primary medical team. And also, it should be notarized or signed by a gazetted officer. So it has to be kept in mind that this should only be applied when the patient is not able to make a decision for himself and when he's terminally ill. So at any point of time, it can be revoked by the patient, either verbally or legally also.
Thank you, Dr. Divya. For the paucity of time, we would not be able to take the further questions. We will be sharing the PowerPoint presentation with you. So just to conclude the session, in Kannada there's a saying, Huttu Uchita, Savu Khachita. So birth is free, but death is always certain. But the quality of life that our patients face from the diagnosis of a terminal illness or of that of malignancy to their final end is what is definitely in our hands, and there is definitely scope for us to improve. Thank you all the panelists, and thank you for a wonderful listening. Thank you.
Thank you.